Hello class, this is Dr. Anderson, and I'm just recording a few ideas about diabetes so that you will be prepared for our class discussion with Dr. Olson. So here's some things to think about with diabetes. Diabetes is about insulin. It's not only about being out of insulin, but it also can mean that you don't respond well to insulin. So we need to talk about insulin and some regulation about that. We will compare and contrast type 1 and type 2 diabetes and why someone would have the classic symptoms. Being very thirsty, being very hungry, having to urinate a lot, having high blood sugar, and feeling tired. Something that can happen when diabetes is not well managed is ketosis and ketoacidosis, so we want to talk about that. One way to think about the complications of diabetes are to think about the things that attack the very small vessels or the capillaries. That's microvascular disease versus the large blood vessels or macrovascular disease. Microvascular disease tends to be associated with poor glucose management, and macrovascular disease tends to be associated with abnormal fat metabolism and atherosclerosis. We'll talk a little bit about metabolic syndrome, and then I'll talk about some new areas of research and some things that I've learned by attending conferences and that sort of thing. All right. So here's a picture that you all should have seen before. Here's a cartoon of an islet of Langerhans. Here's a light microscope picture of an islet of Langerhans. And what tends to happen is the beta cells are in the middle. Those are the ones that produce insulin. And then there's some cells around the edge that produce glucagon and somatostatin. So insulin is secreted from the beta cells. When the blood glucose level goes above 100 milligrams per deciliter or 100 milligrams per cent, then insulin is secreted to try to get the blood glucose level back down. So glucose enters the beta cell via a GLUT2 transporter, so you don't actually need insulin to get glucose into a beta cell. And that increased glucose uptake increases ATP synthesis, then an ATP-dependent potassium channel closes that depolarizes the cell. You get an increase in intracellular calcium, and then insulin is released via exocytosis. So here are a lot of fun facts about insulin. It's a large amino acid, 51 amino acid peptide. It is water soluble, so it dissolves well in the plasma. It has a 5-minute half-life. That's a beautiful thing because you don't want insulin to go overboard and turn around and give you hypoglycemia. It's stimulated by a number of things: high blood glucose level, high amino acid levels, the incretins such as GLP, parasympathetic stimulation, and so on. Insulin works on the liver, on muscle, adipose tissue. So you don't need insulin to get glucose into your brain. You don't need insulin for the kidney and the gut to absorb insulin. The insulin receptor uses a tyrosine kinase and activates a very complicated pathway. And then if it's a high glucose that stimulates insulin, then insulin does things to lower your plasma glucose by getting it into the cell so you can use it or storing it. So you promote glycogen synthesis and protein and triglyceride synthesis in addition to using glucose. How are you able to use glucose in the presence of insulin? That you insert these GLUT4 transporters that allow glucose to get into the cell, and then you have this lots of participants in a pathway of after the tyrosine kinase. When blood glucose level goes back down, that shuts off insulin, and hormones like growth hormone and cortisol are antagonistic. In other words, those raise blood glucose level when insulin lowers blood glucose level. So it's first synthesized as a prohormone, then it's some things are cleaved off of it. Again, it's a very good idea to have a half-life of 5 minutes because you want to lower blood glucose level back to a healthy range, but you don't want to lower it so much that you then go into hypoglycemia. Insulin binds to receptors in the liver, muscle, and adipose tissue. There are some receptors in the brain that do complicated things. You don't need it to get glucose into the brain. Activates a tyrosine kinase that phosphorylates a number of insulin receptor substrates, phosphorylates the tyrosines in those proteins, also increases some transcription factors, and activates some proteins for insulin actions. So here's insulin. It binds to the receptor, which is a tyrosine kinase. Then there are insulin receptor substrates. They get phosphorylated. Then you turn on all kinds of pathways. You're going to get glucose uptake. You're going to activate or decrease enzymes. You're going to get some transcription factors. So it promotes the reaction of the absorptive state. Absorptive state is what that should say. So you get glucose into the cell, you phosphorylate it, you put it into glycolysis, you take the excess and turn that into glycogen. It helps you get amino acids up into the cells, and any extra glucose and amino acids are turned into fat. So insulin, the fed state, when you eat a meal and you stretch your gut and you stimulate the parasympathetic nervous system, that's going to increase insulin. That's a feed-forward mechanism. When you have glucose in the gut, you get the incretins. That stimulates insulin. That is feed-forward. And then when you actually have amino acids and glucose in the blood, that activates the beta cells. And so this is more of a negative feedback mechanism. Insulin then helps you use that glucose and store the store glucose as glycogen, store the extras as fat. So diabetes mellitus is actually a family of diseases and characterized by having difficulty processing glucose, and it gets you hyperglycemia. We should be very worried about it. A lot of people have diabetes, and it's causing a strain on our healthcare system. I actually was listening to an interview this morning where the guy was saying we should tax sugar to try to get a handle on diabetes. We're worried about diabetes because the complications are awful. It affects blood vessels, so people can go blind. People can have kidney failure. People can have terrible neuropathies and pain. Type 1, as you may know, is characterized by insulin deficiency because of an autoimmune attack of the beta cells. Type 2 is insulin resistance. It's associated with being overweight and metabolic syndrome. So glucose intolerance, you know, glucose in very high levels are essentially toxic. And we get worried about when people have had diabetes for a long time, macrovascular and microvascular complications. There's some other things that are involved in regulation. PPAR alpha and gamma receptors. PPAR stands for peroxisomal activating receptors. Anyway, these are intracellular receptors that are activated by lipids and fatty acids, and have some very complex regulation in the body. Leptin is a hormone. Leptin and resistin are hormones that are produced by adipose tissue. So diagnosis of diabetes: more than one fasting blood glucose level that's greater than or equal to 126 milligrams percent. A little lower than that is prediabetes, or an abnormal glucose tolerance test. You take a really large insult of glucose, and then you monitor glucose in the blood and the urine over time. After 2 hours, if your blood glucose level is still elevated, that's a problem. Maybe you get your blood glucose level back to normal, but it takes a whole lot of insulin in order to do that. That would indicate that you are insulin resistant. You can have glucose in your urine. You wouldn't diagnose somebody based on glucose in the urine, but it certainly would say we need to do a screening test. And then a monitoring tool is the glycation of the A1C portion of hemoglobin. Since red blood cells live about 3 months, the glycation of sugar groups on hemoglobin then says something about the kind of glucose environment you've been exposing your blood to over the last 3 months. So diabetes means flow through a siphon. Mellitus means honey. And because there's glucose being lost in the urine, it pulls a lot of water out of the body. So diseases that caused you to pee a lot were called the pissing evil, and diabetes insipidus or diabetes mellitus. And of course, if you had diabetes insipidus, you just had to drink a bunch of water. And if you had diabetes mellitus, then that was a very severe consequence. Type 1 diabetes is insulin dependent. That's a small number of the cases. Basically, there's an autoimmune destruction of the beta cells. When you lose 90% of your beta cells, then you start seeing symptoms. There's a lot of stem cell research going on to figure out how to replace beta cells, how to keep them from being attacked. Insulin independent is more common. All sorts of contributing factors: ethnicity, lifestyle. There are lots of drug treatments. I have a slide I will discuss with that. The insulin resistance occurs not because you don't have enough insulin receptors. You do, but somehow the receptors are not communicating with the pathway beyond the receptor. So post-receptor effects is a big part of the diabetes research. You make more insulin to try to get a response to insulin. So before you have hyperglycemia, initially you'll have hyperinsulinemia, and diet and exercise are very, very important to management of diabetes. So look at all the drugs. There are drugs that will stimulate insulin secretion. So if you have some beta cells, you can activate the beta cells you have to produce insulin. You can block absorption of insulin from the gut. There are also drugs that block reabsorption of glucose in the kidney. Metformin, we're not totally sure how it works, but there's some liver effects. Gluconeogenesis is a process where we make new glucose in the post-absorptive state. Sometimes if a person is unable to use glucose because of insulin resistance, they will perform inappropriate gluconeogenesis. And so it's believed that metformin stops the liver from performing gluconeogenesis inappropriately. So here's the PPAR activator. So you're activating the PPAR gamma that increases insulin sensitivity. amylin analogs, incretins, analogs of GLP-1, for example, and or preventing the breakdown of GLP and GIP. So major pathophysiology, if you have difficulty getting glucose into your cells, it's going to build up in the blood, and that causes hyperglycemia. Those osmotic particles are filtered by the kidney, and so you have lots of osmotic particles pulling water out of the body and causing dehydration. And if you can't use glucose, you will try to use fat. And when you break down fat, a byproduct of fat metabolism is the development of ketones. And when ketones are in excess, that causes ketoacidosis. Very complicated chart, holy Toledo. So, if you are unable to release insulin, then you have difficulty storing fat. You will break down fat, and to try to have a substrate so you can make ATP. Breakdown of fat increases ketone production, and that promotes an osmotic diuresis. If you have difficulty getting glucose into the cell, then your liver makes things worse by performing gluconeogenesis, and that adds to the hyperglycemia. All these particles increase the osmotic pressure of the filtrate and the urine that pulls water out of the body, causes dehydration, loss of blood pressure, and people can go into circulatory shock. Metabolic syndrome is a combination of type 2 diabetes, high blood pressure, and atherosclerosis. So people have abdominal or central obesity, a high blood pressure, high fasting blood glucose level, high lipids, and low HDLs. HDLs are the good cholesterol. So there are a number of things going on. Micro versus macrovascular complications. The small vessels like the capillaries are microvascular complications. It's associated with elevated blood glucose level. So I really shouldn't have glycosylation. I should have glycation. But you add sugar groups to things and you turn things on inappropriately. You activate diacylglycerol protein kinase C. You get endothelial dysfunction. And what that results is neuropathies, and burning pain in the extremities, glomerulonephritis, visual impairments. Now, macrovascular is the larger vessels that's associated with hyperlipidemia and atherosclerosis. So this results in cardiovascular disease, stroke, and heart attack. And this can occur in people even if they're doing a good job with their blood glucose level. Typically, though, people that are having trouble managing their diabetes will have both aspects. A lot of damage to the cardiovascular system. So some interesting things. If people are overweight and having difficulty managing their diabetes, they may have bariatric surgery. One type of surgery is the Roux-en-Y, where the stomach is made smaller and the duodenum is bypassed to decrease some reabsorption. An interesting thing is that almost overnight people have improvement of diabetic symptoms. It's not really known why. One big possibility is that you change the gut microbiome, and the bacteria in the gut are having a profound effect on how you respond to insulin and how you process glucose. However, if people don't change their ways, the insulin resistance can return. So, and this is just a really, really invasive intervention, but for some people it's what they need. So, here we go. Peroxisome proliferation activated receptors. So these are intracellular receptors, and they bind lipid. So the PPAR alphas we see a lot in the liver, and that helps decrease plasma lipids. The PPAR gammas are drugs that for diabetes, and so one of the things they do is they get fat out of other tissues and deposit it in adipose tissue. So people may actually gain weight, but the thing is, that's what your adipose tissue is for. It's supposed to store fat. You're not supposed to have fat in the liver. You're not supposed to have fatty liver. You're not supposed to have fat in the skeletal muscle. And so by getting fat out of inappropriate cells and getting it into the adipose tissue, you essentially increase insulin sensitivity. Leptin and resistin are hormones that come from adipose tissue. So when you increase fat stores, that's called an increase in adiposity. That increases the secretion, so you get more resistance to insulin. So there's something called the lipostatic hypothesis of weight maintenance. So you gain a little weight and you secrete more leptin. Leptin decreases your appetite and improves your metabolism, increases your metabolism. So then you lose the weight. This is why it's really hard for people to lose weight, because you lose weight, your leptin goes down, your metabolism goes down, and your hunger goes up. So you've lost some weight, but now you're unbelievably hungry, and it's hard to keep the weight off. It really is terribly unfair. You also have a hormone that comes from your stomach, and when your stomach is empty, you produce ghrelin, and it tells you you're hungry. Ghrelin secretion is disordered in people with obesity. That's a really hard thing when people are just this overwhelming hunger that sort of pervades their life. It really is a difficult thing to try to think about long-term strategies for losing weight. So think about if you have any questions. I'm just going to go on here a little bit. I have some other slides, and I'll share some additional things I've learned at some conferences about diabetes. So there's some interesting research going on to find out what happens to the glucose that happens in glycogen. So if you're a healthy person, you take extra glucose, you make it into muscle glycogen. Turns out people with type 2 diabetes have a hard time storing muscle glycogen, and it may be contributing to their insulin resistance. And the problem is the GLUT transporter is not being inserted properly, so you can't get glucose into the muscle, and then you can't make glucose into glycogen. So there are all kinds of interesting things that are contributing to a person's inability to respond to insulin. Another thing is lipid metabolism gets messed up in type 2 diabetes. So if you have fat in cells that aren't supposed to be storing fat, as opposed to adipose fat, that is an incredibly strong predictor of type 2 diabetes. So when somebody eats a high-fat diet, that activates a diacylglycerol protein kinase C pathway that opposes the tyrosine kinase pathway that interferes with insulin signaling, and you deposit fat in the muscle, in the liver, instead of in the adipose tissue, and that interferes with your ability to respond to insulin. There's a strange condition where there are people that are born without adipose tissue, and it's called lipodystrophy. And since they don't have adipose tissue, the fat goes into the muscle and liver. They're extremely insulin resistant. They have extreme hyperglycemia, and they're absolutely ravenous. And they may be actually quite thin, too. It's not a nice disease. But it turns out these patients are helped very greatly by leptin treatment. and it ends up normalizing their insulin response, and their appetite normalizes, and it really is very, very helpful. How do you help people with type 2 diabetes? They should be on a 1,200 a day kilocalorie diet. They should be getting lots of support through counseling. And even if you just lose 10% of your body weight, you're losing the fat out of the liver and the muscle. And that improves your insulin response. That's how these PPAR gamma drugs work. So here we go. So I'll end it here, and I'll talk to you in class.